Okay. LDN and Toradol, ketorolac, dexamethasone, Benadryl, migraine, just in the past at lower LDN. So again, and I mentioned this, and it was a very brief statement, we're using LDN as an adjunct medicine because we're taking away a lot of the drivers of inflammation. We're doing that immunomodulatory response, but we're also having this endogenous endorphin response and this blocking response in some of the opioid receptors. And so you're really, really kind of messing with multiple systems. And so when you're adding different IV medications and then you throw in another immunosuppressant and you throw in a antihistamine medication, which has multiple different system effects, we see sedation with Benadryl. And then we can actually see these other IV drugs coming on board. We're really intensifying their effectiveness because we're removing a lot of the drivers that are present that they're required to do their job. So we start to see different side effect profiles of these medications because they're just working better. Dexamethasone, you said psychotropic. I'm going to use the word dissociative symptoms. Usually that's an indication. If you get dissociative symptoms with Toradol and dexamethasone, the first thing I think is like, ooh, we went way too high with the dose. We might be able to get away with lower doses in these patients. So, or your naltrexone is kind of optimized and now we may not necessarily need as much. So might be a recommendation is come in with a little bit lower doses, especially with dexamethasone. That is a wild drug for people. Some of the side effect profiles, ask a pharmacist, they'll tell you it can be pretty wild stuff.